One of the major challenges in devising an antiemetic regimen prior to chemotherapy is really considering the setting that the chemotherapy is going to be given. In the United States, most of the chemotherapy is given in the outpatient setting. Then, if it's given in that setting, we really have to look at the multiple formularies that are seen amongst all the different insurance carriers. We know that a lot of the insurance carriers will have their own formulary. We know that the antiemetics on those formularies can be significantly different, and it's a challenge to make sure that patients are given what's on their formulary to avoid large copays and other coinsurances. The other reason that you need to look at the setting is different models in those outpatient settings lend to different reimbursement platforms, and therefore some agents, whether they're oral IV, may be utilized instead of another agent because of the way that reimbursement is set up in that clinic. Thirdly, each company, as far as antiemetic manufacturer, will have its own patient support and patient assistance program. And again, these programs can vary widely amongst the different companies. Some have a income eligibility requirement, others do not. Some look at whether you are a Medicare patient versus a commercial payer, and it will have different support based on the type of insurance that the patient has. And again, this can be very challenging trying to keep track of all the different programs that are out there. Another unmet need is, from a logistical standpoint, is really trying to marry all the different EMRs and different technology systems from the outpatient pharmacies where some of these medications are dispensed to hospital or clinic EMRs or IT systems. This has been a major problem in really trying to figure out what patients have gotten in the past, either to prevent or to treat their CINV. And this would be very helpful that when patients come in for subsequent cycles, we can kind of look at their medication history and what they have gotten in the past versus what we can potentially use in the future. Also, from a monitoring of drug interaction profile, if there's ways that we can kind of marry these EMRs or electronic medical record systems together would be very helpful and beneficial in giving a patient a complete antiemetic regimen with their chemotherapy. A lot of the new antiemetics that are being developed today really are oral agents. And this has been very convenient for the patients to take. However, it does lead to a challenge, at least from the healthcare provider standpoint. We know that sometimes adherence to oral therapy, whether it's chemotherapy, whether it's antiemetics, or whether it's chronic therapy such as hypertension medicine or arthritic medicine, the compliance and adherence rates can be in the 50 to 60% range. And we see the same with oral antiemetics, that sometimes it's a challenge to get a script to a patient, to go to their pharmacy to get it filled, and then for the patient to remember to bring that script in so that they will take their antiemetic properly. One way that outpatient clinics have tried to combat the adherence problem is to develop in-house dispensing. This is where the outpatient clinic will have their own pharmacy within the clinic where they can go ahead and give the patient their oral chemotherapy or oral antiemetic therapy the day of chemotherapy. This has really helped with the adherence problem that clinics that do not have in-house dispensing sometimes run against. Patient education is very important when we talk about prevention of nausea and vomiting in patients receiving chemotherapy. We really want to make sure that patients understand that nausea and emesis with chemotherapy is something that we should not expect. In fact, that we can do a very good job of controlling almost to the point where, at least in the first 24 hours, that they have no emesis or should not expect to have any emesis. We also need to make sure that they understand that if they do have emesis with their chemotherapy at any point, that this is not a failure of their chemotherapy, and in fact, this is something that we can try to treat, and they can continue therapy, and it will have no effect as to whether the chemotherapy is working or not. There certainly needs to be continued support from a patient education standpoint. We need to continue to do a better job of telling our patients prior to chemotherapy that if you have any nausea, please to let us know early on in the process where we can do something to manage it. because we know that as the emesis cycle continues, it gets harder and harder to treat, whether it's with that cycle or the subsequent cycles. We know that emesis and nausea really is a learned response, and that the earlier we can treat it and prevent it, the better off that we're going to be.